I think it's now time for our panel. The panelists, please come forward.
All right, we're going to try and get in 2 quick cases and try to still finish this on time. So if we can get our panelists up here. Since we only have time for 2, I'm going to skip ahead, actually. I'm going to skip this first case.
Thank God.
All right, so this is the first one we're going to start with. We're just going to jump right into it. So this is a 78-year-old woman initially referred from the ER for a tender bleeding perianal mass, and on exam you see something prolapsing through the anal canal that's about 1 to 2 centimeters in size. Medical history, she is not a very healthy woman. She's had a history of an MI with 2 stents in the last 6 months, CHF, and a clotting disorder actively on Effient. Surgical history for a sigmoidectomy for diverticulitis. So this is just her clinical course. So she got a biopsy. It turned out to be a cancer, an early cancer, SM2, SM3 with positive margins. She refused an APR. She refused radiation because of her other medical comorbidities and was unveiled into surveillance. And 1 year later, she recurred. She had a staging CT, which demonstrated a new lung lesion that was a primary lung cancer. So she had a lobectomy, and then she had a robotic APR. Uneventful DC to rehab on post-op day 4. Final pathology was a T2N0 with negative margins. So she comes back to see me in the office. We're now at post-op day 12, feeling great. She was telling me and her daughter how surprised that she was as active as she was. As I do with all of my APRs, I leave a pelvic drain in. And I went to pull that pelvic drain. And when I went to pull the drain, I tugged a little bit and she sort of winced. So I pulled a little bit harder and she winced a little more. And then, like my chief told me when I was an intern, just put your foot to the bed. So that's what I did. And I pulled the drain out. And she had a fair amount of pain after that. Lasted about 15 to 20 minutes, but subsided and she walked out the office. Any of you guys worried about that?
I'm sure it's nothing that you're presenting it here at the panel.
Yeah, absolutely.
Everything's going to be just fine.
Yeah, just fine. She shows up to the ER the next day because she's still having pain. She had completely gotten herself all the narcotics when she saw me, but she was back on them. And despite that, she was still having abdominal pain, has a white count of 20. They do a CT scan, and this is what it looks like. So you see a little bit of sub-Q air, intra-abdominal. Everything looks pretty good. No free fluid, no free air. Did you guys see anything that you were worried about on that CT scan?
Can you go down the pelvis?
Sorry, that's as low as it went. Would any of you act on this CT scan? Abdominal exam is fairly benign, soft, focally tender in the right lower quadrant, tender right where the drain was pulled from.
So she's post-op day 13? Right.
At this point, she's post-op day 13, correct. Hemodynamically stable, white count of 20, afebrile. She feels okay except for the pain in the right lower quadrant.
I guess I'd be concerned with all that stranding in her abdomen. It's a little more than I would expect at post-op day 20, or 13, sorry. And a little bit of free fluid as well. So.
When do we go to the OR?
Yeah. Honestly, the way you describe it, and first of all, I need to know who the chief resident was that told you to do that. I would be concerned that there was like some small bowel injury, like there was a small bowel stuck on the drain or wrapped around the drain, and when you yanked it, you probably ripped it open.
Yeah, I would be concerned about that as well. I can only tell you when I was a chief resident, I was told the same thing, and I went to pull a drain once, and the thing came loose, and the drain came out of the patient, went and smacked me in the middle of the forehead, and I had a drain scar right smack down the middle of my head for like a week, and that's not a lie. I have pictures of it somewhere. But I would be worried about the same thing. I mean, obviously, there's a couple of things that come to mind. Is there some weird sub-Q stitch that caught the drain into place? I mean, I've seen that happen before, that it has nothing to do with intra-abdominally, but it's something during a closure. I've seen drains get caught in like a closure before, but I always do worry that something's weird with an enterotomy. Obviously, you have the benefit of seeing the patient in front of you, palpate in the abdomen. If you would think 24 hours later or whatever that if she had small bowel enterotomy, she'd have pretty close to peritonitis, and you should be able to tell that on physical examination.
Was that a Blake or a JP?
It was a JP drain. So yeah, like you're saying, so at the bedside, she looks great. She's lying in bed comfortably. She's like up and walking around the unit, but just focally tender on exam in that right lower quadrant. Is that enough for you guys to take her to the OR?
She's not tachycardic. She's not tachycardic.
Hemodynamically stable.
No, not yet.
I'd admit her. Antibiotics and
Give her C.
give her C.
All right. So yeah, that's what we did, and I was hoping we'd get lucky. So hospital days 1 to 3, made her MPO, put her started IV antibiotics. White blood cell dropped from 20 to 12 to 10 by hospital day 3, and the abdominal pain was improving as well. So I thought we got away with it, and I was telling the family we're maybe another day or two in the hospital. Hospital day 4, she starts to get worsening abdominal distension. Still minimal abdominal pain, still looks well. White counts up to 15. Still afebrile, still hemodynamically stable. Hospital day 5, persistent distension. Now she's got some nausea, vomiting. NG tube goes in. Low-grade tachycardia, 100 to 105. White blood cell count of 20.
I guess, I mean, we all know where this is headed. But I guess you could fool around and get a CAT scan just to get an idea of what you're dealing with. I'm not sure that's going to, well, there you go.
We had some time before the OR. This is what you see on her. See, this is actually done between hospital day 4 and hospital day 5. So you see now a little bit new free fluid above the liver, a little bit of free air, distended.
Like I mentioned in my talk, people get CT scans when they're septic and need to go to the OR. We all do it. So you knew you were headed that way, but maybe the scan made you feel like you were doing the right thing.
All right, so everyone agrees she's going to the OR. Okay, so this is what we find when we get to the OR. As soon as you open, starts overflowing with bilious fluid. We're able to separate the omentum from the abdominal wall and the small bowel, but essentially the entire abdominal contents is moving en masse. There's one loop of small bowel that's tethered deep into the pelvis. My first move was to try and free up that loop, and just with trying finger dissection, I made 2 enterotomies in that loop of small bowel in the pelvis, one of which I was unsure how we'd be able to repair because it was so close to the pelvic sidewall.
Yeah, so when you take these patients back, I always tell our fellows, not that I've ever taken somebody back like this, but what I've read about is the fact, I think warm water is your friend, and I have them get liters and liters of warm water just kind of let that sit, and I do a lot of, not true hydrodissection, but I do think that it's a difference, and I found that more than anything helps, especially, we tend to get anxious, our blood pressure's up, and you get fat fingers, all of a sudden you start to do exactly what you did, and it's no fault, but there is a point in time where you got to say to yourself, maybe the best thing to do is in every surgeon's ability, you got to know how eloquently to bail, and sometimes it's oftentimes when you don't want to bail, you're like a little bit more, and you're like, oh shit, I should have just stopped a little bit ago, and and where you're going to leave your drains and what you're going to do, because the worst thing you want to do is find yourself either just with an open abdomen and just mass drainage, or even that high jejunostomy where you make it further. So at this point, you have to have a realistic expectation, because you're there and you got to say, am I literally going to be able to progress or not? And if not, then I need to do wide drainage and get out of Dodge.
Anyone else? Thoughts?
Escape.
I sent her to Steele.
I would take that loop out of the pelvis. You got into it already twice. You know that loop's coming out. It's stuck to the bone. It often is. When I've gone back on bowel obstructions and after APRs, that loop's always down there. And almost every time I've gotten into that loop, so that loop's coming out, I would go after it and do a resection.
But I mean, theoretically that's great, but if that means you're going to make 4 more holes, which is what it sounds, or 6 or 8, even with a veritable Nile of warm water. If everything is
that funny, Robbie.
stuck and that friable, and you move your hand and there's a new hole forming, you're just going to make matters worse. So it's a horrible, horrible, horrible situation. But you have to do what's achievable and think about the downside. Again, none of us are there to decide with you, but I would be thinking I'm just going to make 4 more or 6 more of these holes.
Yeah, the only other issue too is, especially when it's down in the pelvis, the thing that I worry about is, making enterotomies is one thing, and you can lay wide drainage, but if you're really stuck against something that's really friable, blood vessels, and now you find yourself in a deep down hole that starts to bleed and you can't get access to that, then you're really in a situation where you do not want to be in. And so, again, we've all been there, and you've all made mistakes and gone too far, but I think that with increasing experience of being there, that it is an eloquent decision of how you learn how to bail.
So that's what I actually did. So I attempted to bail. I went out and talked to the family and gave them the options. Family wanted me to keep going. I told them that if we kept going, there's a likely chance that we'd make more injuries. What I recommend is maybe we just pull up a loop of small bowel proximal and widely drain and hope that we could divert proximal to wherever that injury was. But good thing is better lucky than good. So in the process of doing that, I ended up finding that loop of intestine, and while we were trying to pull up a loop to just hang it, we uncovered what looked like to be a dime-sized chronic appearing enterotomy stuck right at the sacral promontory. We were able to lyse that last 100 centimeters of terminal ileum, and that's where that injury was, and the two enterotomies were encompassed in that terminal ileum. So now what we have is we have 3 holes in the bowel around 100 to 120 centimeters proximal to ileocecal valve. To resect it, there's probably about 30 centimeters of non-viable bowel. So what would you guys do at this point? Would you resect the bowel and bring up essentially a jejunostomy? Would you put her back together? Would you put her back together and divert?
I'm not sure I'm understanding the anatomy here. So you've got a small bowel injury with the 3 holes, all encompassed within 30 centimeters?
All within the 30 centimeters.
And you're 100 to 120 centimeters from the valve?
The most proximal extent of that is at 120. To bring up a loop proximal to all the injuries is about 100 to 120 centimeters in front of the ileocecal valve.
So you have a 30 centimeter segment of bowel mid-jejunum that you have to deal with, and all the bowel around it's
okay.
All the bowel around it's okay?
No, so I only lysed up to that 120 centimeters.
And the rest, you just looked at the fellow and said, "What'd you do?"
Yeah.
So you're 100 to 120 centimeters proximal to the ileocecal valve, and you've got a piece of bowel that's alive?
No, that 30 centimeters is non-viable.
Okay, so then you're 150 centimeters proximal.
No, so from 90 to 120 centimeters proximal to ileocecal valve is where that non-viable bowel is.
With 3 enterotomies in it.
With 3 enterotomies.
Right, so I mean that piece is coming out.
Okay.
And now.
Yep. So that piece is definitely coming out.
Yeah. Okay. So and the other piece, you mean you're not just doing an ileostomy with that thing and declaring victory?
No, you're mid-jejunum.
It's mid-jejunum. This is all mid-jejunum.
So
120 centimeters up. No, you're not. I would take it. I would take that.
You would just give him an ostomy at that 120 and
Yes.
take the.
That's not mid-jejunum. That's going to be distal jejunum. You'll be okay.
Distal
She'll get
jejunum.
through that. She'll be alive, man. Just bring up a stoma and go have a beer.
What's your nutrition?
Bring up a stoma, baby. You'll get her through that.
Nutrition was actually adequate. Albumin was in the 3s. Pre-albumin was around 18.
That's before you started this operation.
That's before we started. Correct.
No.
So just close off the terminal ileum and bring up an end.
Well, I would bring both of them up. I'd have the other one in the subQ, buried in the subQ, and bring up the other end. Stoma, it's got to be high output. You can control it, at least for the time being. Get her out to 3 months. And then,
6 months.
well,
She's stable?
If you can. 6 months ideally, but
You tell them 3. Then at 3, you're like, let's wait a little longer.
Is she stable?
Stable. Correct.
I'd hook her up.
the bowel is fine.
You'll be back in 3 days.
What's the bowel look like?
The bowel in
Looks
this area,
dead in 30
the bowel in this
centimeters.
area actually, once we got proximal
Hold
to
on.
the injury, that bowel actually looked okay.
I would hook her up.
So that's what I did. I hooked her up.
What'd you do the next 3 days?
I hooked her up.
We prayed.
I drained.
You put a drain in?
Yeah. We put 2 drains in.
Did you stitch it to the anastomosis?
Right to it. Right to it.
It comes out easier that way.
And I told the family, I wasn't sure if I even got the hole. I was fairly confident, but I wasn't sure. Would you have lysed more adhesions at that point to see if you saw anything more?
No.
Okay, good.
I mean, a proximal ileostomy, distal jejunostomy is not benign.
That was my feeling as well.
I agree with you, but the bowel looked good, her nutrition's good, she was stable. Why not hook her up? It's a small bowel.
So
Because
that's
she
why I
has
said better lucky than good. She ended up
peritonitis.
healing up. She came back she got out of the hospital day 6. We pulled those drains out in succession, 7 and 10 days after surgery. So on my APRs, I flap all of them. And so I have a drain sitting above the flap, I have a drain sitting below the flap, and I wait till that drainage is relatively low before I pull it so that the wounds heal. Nope. I changed my drain. I use the Channel Blake drain now instead of the JP drain.
Thank you.
Yeah, but I don't use the JP anymore. All right, here, case number 3, so definitely not lucky. All right, so we have a 6-year, do we have time for this, Wolf? All right. We have a 6-year-old guy with anal cancer. As part of his pre-treatment, he had a colonoscopy where I had to actually abort the colonoscopy because there was a tight angulation and stiffness of his sigmoid colon. And there's a bunch of diverticular disease in the area. He was asymptomatic from a GI standpoint aside from the perianal pain from this mass. We tried to do a CT, a virtual colonoscopy. We couldn't get adequate insufflation because of the stricture. Do you want to do anything about that? He's asymptomatic, pooping, eating, no problems. Anyone?
This is just a stricture in the sigmoid, probably from diverticular disease, we think?
Yeah. So it's just
Had
something
a
I can't get
CT that
I can't get my
didn't show
scope through, but no
There's
signs of
mass,
obstruction on the
there's
CT.
no intrinsic mass, nothing, no obstructive
Nope.
signs on this. I'd treat the anal cancer.
Anyone else? Okay. So he goes on to chemoradiation. So here's his post-radiation course. 6 weeks post-radiation, he has a posterior midline ulcer. Looks like there's probably still something there. At 12 weeks, that ulcer is still there, but unchanged. It hasn't grown in size. At 16 weeks, he gets admitted to the hospital for worsening abdominal pain. And on that CT, he shows thickening of a sigmoid colon extending to the rectosigmoid junction, and there's now a 3 by 2 centimeter abscess abutting the dome of the bladder. Hemodynamically stable, white count of 16. Calling it as diverticulitis, perforated diverticulitis with abscess.
Antibiotic.
Okay, do you guys want to drain it?
No.
Will they drain it?
If they want, yeah.
You're right on the edge of needing a drain at 3.
So we left it alone. We didn't drain it. We put him on antibiotics. He did fine, passing gas, having bowel movements still. Got him out of the hospital. He comes back 20 weeks, admitted worsening abdominal pain, distension, now with nausea and vomiting. CT, abdomen, pelvis, repeated. Now shows that persistent thickening of the sigmoid colon, now with a high grade or complete bowel obstruction. But the abscess is better. Incompetent IC valve, small bowel dilation as well. And to make things worse, on the perineal exam, there's now a mass, 2 centimeters. So what do you want to do now? Summary, we have a guy with a new large bowel obstruction to a restriction of the rectosigmoid junction, 20 weeks post-radiation with progressive anal cancer, contained perforation with pelvic abscess. Smaller. It's down to 1 centimeter, the abscess. Dr. Steele, what do you want to do with this guy?
Yeah, again, I think you got to say to yourself, I mean, obviously you got somebody who's failed the chemoradiation therapy and is ultimately going to probably need an APR for this. But in the acute setting, you have this high-grade bowel obstruction with, with proximal dilatation. He's got a competent ileocecal valve, and I think you said his colon was pretty massive. So, is this a guy that you're going to go ahead and you're going to take everything out and put him through a huge operation, or you do just want to, divert him up front, cool him down, let everything go the old-fashioned, 2-stage or 3-stage procedure that we don't do much anymore, understanding that by just diverting him alone would avoid the stricture, would allow his bowel to decompress, and ultimately you're going to take down, and because he's going to need this APR, and you can take that down and block. Or you're going to, just resect up front. He's probably not the guy that just sounds like that I'm going to acutely take for what it would amount to be a sigmoid resection all the way down proctectomy APR.
That was an anal squame, right?
Anal squame, correct.
Yeah, I agree with Scott.
So if you divert, so none of you would want to resect right now?
Probably not.
If you divert, what would you divert with?
So what did you resect him with?
What's that?
You already gave it away. You have an incompetent valve.
Yeah.
So you diverted with the loop ileostomy.
Well, I'm not asking what you think I did.
I know,
What
but
did
that's
you
what
do?
you did.
Because that's you hinted it's
Okay.
like we're reading your book.
Right. Because the
So that was not my plan. My plan initially going in was to divert him with a colostomy because I knew he was eventually going to come for his APR with his progressive anal cancer.
That
to
would
just
be
save us one
easier.
step.
That would be easier, but depending on how dilated his colon is, you might, if you can stay lap, do an ileostomy as opposed to a colostomy. But I agree, a colostomy up front would be easier.
Would you guys try to do this lap?
Yes. Yeah, what's his domain and how he's down, but yeah.
Okay, so that's what we did. So we put the NG tube in and we decompressed him actually for 2 days.
Yeah, that helped.
Which helped a lot. So we end up being able to get a scope in. My plan was to do a diverting loop colostomy, but unfortunately his entire sigmoid was plastered to his sigmoid fossa, and he did not have a very redundant bowel, so I did divert him with a loop ileostomy. Okay, so he is now 2 weeks post-op. He's doing well with the diversion. His abdominal pain is resolved. He's completed his antibiotics for his diverticulitis. What do you want to do about the progressing anal cancer?
Hey, Mark, did
Yeah.
you, at the time of the loop, did you rebiopsy the mass?
Rebiopsy the mass, correct.
And it was
is
confirmed cancer?
anal cancer,
Okay.
correct. Restaging, PET CT does not show any signs of metastatic disease. But this is clearly progressive anal cancer. We are now 7 months
And colon
post-
cancer?
What's that?
And colon cancer?
That we don't know.
Yet?
Why are you always so cynical? What do you guys want to do? Dr. Alavi?
So it's 7 months post-radiation,
And 2 weeks post-lap loop ileostomy,
and you had an acute process
2 weeks ago.
to go. I'd probably wait at least, 4 weeks before I do anything. Make it a little bit easier to get, take down that sigmoid when you're in there. But, he's going to need an APR with an extended sigmoid colectomy. Probably has to bring out a decent interview colostomy.
Dr. Steele?
And flap reconstruction.
Flap reconstruction.
Yeah, again, I think you got to optimize this patient as much as possible. You don't want to wait too long till he has progression of disease. There's some fine balance in there somewhere. I'd be looking at those nutritional components. If you can wait a couple of weeks, let things simmer down. But the realistic, if it's as plastered as what you say it is, in a couple more weeks, it's probably not going to get that much better. Yeah.
I will say one thing though. With the diverting loop ileostomy, the only issue with that is with the anal cancer, if there's the tissues are severely irradiated, and you're not going to bring them together primarily, and you're going to have your plastic surgeons involved to create a flap, and that limits their options. They can't use the rectus abdominis to bring down and flop down there because you have your loop ileostomy there. So that's the only thing that would convince me or made me go towards doing a loop colostomy if I could, which sounds like it could.
Plus, when you need two stomas, because it's actually a cancer that's invading his bladder, and that comes out.
Dr. Sklow, how long would you wait?
Oh, are you planning on taking the ileostomy down and giving him a colostomy?
That's my plan, is to reverse the ileostomy, give him a colostomy, and do an APR.
So I would probably wait a month, a total of 6 weeks, and then taking the ileostomy down, probably doable, and then do the APR.
Dr. Madoff, your same 6 weeks, 4 weeks, longer? Doesn't matter?
When he's in tune.
When he's in tune.
4 to 6 weeks.
4 to 6 weeks. Okay.
6 weeks total from when you gave him the ileostomy. So another month, like Karim said.
Okay, so I waited a little bit longer. I gave him 6 to 8 weeks, mostly because he was pretty deconditioned. But we did end up back in the OR, so we got pre-op cysto stents. Once we got in there, everything in the pelvis was like concrete. Everything from the sacral promontory on down, there was not a single normal plane. The only way I found the sacrum is because I started to get bleeding. Dr. Madoff, what should I do? I actually called you. You didn't pick up your phone. So now here's your chance to answer. What should I have done?
Transfer to Mercy.
What do you do for these pelvis that you...
Do you think this was inflammatory from the thing in his sigmoid?
I could not tell. It was literally like cutting through a block of scar. I didn't know it was
Okay,
fibrosis
well,
from the radiation or inflammation from the diverticulitis.
Yeah. You're in an unsafe situation if you're in the pelvis and you can't see anything. This is maybe arguably, I'm still wondering about this thing in his sigmoid, but if it's diverticular and he just has a tremendous inflammatory thing and the anal cancer is not growing visibly day by day, I would get out of there and give him another 6 weeks or whatever you can do. It would seem to me to be the safest thing.
So at this point, once I operated, he actually had this huge mass. I couldn't even do a digital rectal exam anymore.
That's what, all right, so then he's in a terrible way.
Yeah, you're not gonna. I mean, I would pull out at this point. And, but because this is it's showing an aggressive biology, and your surgery is not going to cure him. And now you're getting into the whole palliative treatment.
I'll bet you
Dr.
he
Steele?
resected it, though.
Dr. Steele, would you have stopped at this point?
Yeah, I think I go to Robbie's point. I think you got to take a step back at certain situations and say, what do you really think's going on? Which is hard when you're focused and you're in there operating because you're like, this is my one shot, and I dug all the way down there. But the reality is, if this anal cancer is growing that bad in that short a time, then you got to say this is a pretty. Also, by the way, it's one that's failed the NIGRO protocol. So you got to think about salvage rates with APR and how good those are, and what's your best option to make sure that you get an R0 resection. You know, now you take another step back to Rob's point and say, now, if it's truly concrete, now I'm not really even doing a great operation because I have no idea what my planes are. I'm probably going to leave tumor behind. This guy's probably not going to do very well, and I forgot already how old he is, 60 or something like that. Your best bet is to try to get out of Dodge, put him some extended time out, which by that time sounds like it's going to be a metastatic disease or it's going to start just growing anywhere, and so I would bail.
Dr. Sklow?
I would phone a friend.
Phone a friend, I did.
He doesn't answer.
Get another opinion.
I did.
Did they come up to Mercy?
Yeah. Do you know who that friend was?
Yeah, it was me.
Yeah, that's right. Unfortunately, at the time, I had already committed and taken the pedicle by the time we got into like fairly significant bleeding. Eventually, we did carve this thing all the way down to the pelvis, leaving a little rim of mesentery along the sacrum. But I did have Dr. Sklow, and we did end up taking this whole thing out. But we made multiple proctotomies in the process of doing that.
So
What's the path?
yeah,
The margins were clear.
impossible.
So that was all inflamed mesentery?
It was all inflammation. It was all inflammation. The margins were clear from the squamous cancer. Yeah.
How'd you close the hole?
Gluteus rotational flap, which ended up having some breakdown because the tissues on the perineum were just as bad as what they were on the inside. But he had a small sinus that came off of that flap, but plastics got it healed within 3 months.
Sweet.
I should have stopped, like you guys said.
No, I don't agree.
6 months
No,
later.
I mean, if I would say if this was not cancer growing there, I mean, you're committed once you took the pedicle.
Yeah.
But otherwise, in retrospect, I would still say if this is all diverticular stuff, you probably, I mean, this story came out great, and congratulations to you and Brad.
Well,
but
this story did not come out great.
Oh, okay. But yeah, I mean, you could have also just, cruised into his iliac vein if you can't see where you're going and had massive hemorrhages. It's bad enough operating the pelvis, period. But if you can't see where you're going, there's tiger country.
6 months later, this patient popped up with mets in his liver.
Yeah, that goes back to the comment on tumor biology. And what you really got to say to yourself is, what is this patient in front of you? What's their long-term goals? And I don't know, Robbie. So you took his pedicle. So what? I mean.
Well, if the sigmoid is dead, you have to get.
Oh, so was it dead? I mean, just because you took. I mean,
Yeah, I mean, if it's alive, if you're alive,
dead.
you're not doomed. And then but if you took the pedicle and think you have question viability, then
we probably could have left part of the rectum and just transected in that upper rectum. It would have been in this like fibrotic tube that we would be transecting through. But the proximal sigmoid colon or the distal sigmoid colon after we took the pedicle was no longer viable.
The only thing I'd say, and I would say most surgeons in the room have a similar story, but I almost killed a 42-year-old guy in a Hartman's takedown because I got in a very similar, very difficult pelvis. And the issue is that somebody gets a gunshot wound. Obviously, I've been to combat many times. You get a gunshot wound in the pelvis, and you can move things around and take care of it. You get a rock-hard pelvis, and you get an iliac injury. Nothing moves. You're in a hole that you can't see, and you can't go from there, and those patients die. And it was the scariest thing that I've ever been to, and it gave me a whole new appreciation for true pelvic bleeding because I was fresh out of combat. I thought, God, I can handle most of these wars when people get blown to pieces. I know how to stop major bleeding. And then you get into a frozen pelvis that's concrete, and things go wrong, and you can't pack. And you pack right, and they still bleed. And that's a scary position you want to be in. And I would say it takes only one of those to kind of rechange the mind of what you're doing, to go to Robbie's point. Let's go have beers.
All right. Thank you, guys.